Hello everyone, I'm Dr. Lee from Princess Margaret Hospital. Welcome to Lesson 2 of the Pediatric Sedation Training. In this recording, we will discuss pre-sedation assessment, preparation for sedation, and procedure-specific requirement for sedation. The doctor in charge or sedation doctor should perform a thorough pre-sedation assessment scheduled with ample time before the procedure. He or she should focus on risk assessment and determine who are suitable for providing sedation. Pre-sedation assessment should take into account patient factors as well as procedure factors. Medical history regarding general health status such as major illness, physical abnormalities, neurological problems should be obtained. Cardiovascular diseases such as congenital heart disease or pulmonary hypertension, respiratory diseases such as asthma or URTI should be noted. Other relevant issues including history of snoring, OSAS, history of previous sedation or GA, any adverse drug reaction or allergy, and use of current medication. The next step in assessment is a thorough physical examination that includes the usual demographics and vital signs. We should also examine the CVS, respiratory, and neurological status of the patient. Special attention should be paid to airway assessment as well. In assessing the airway, we should look at abnormalities in the head and neck, such as small or receded jaws, mouth breathing, or big tonsils. Grading of tonsil size should be done, as increased size is associated with upper airway obstruction during sedation. Scoring system, such as Mellon-Party classification, can be used to assess the size of the tongue relative to the surrounding structure and the degree of difficult airway during intubation. Airway assessment also includes examination of the neck for shortness, limited extension, spinal anomalies, tracheal deviation, and surgical scars. Presence of stridor indicates airway obstruction. Abnormal airway can be the result of congenital, traumatic, inflammatory, or neoplastic etiologies. There are numerous causes of congenital airway problem in pediatrics. We should make a systematic assessment starting from the nose, nasopharynx down to the tongue, mandible, maxilla, pharynx, and trachea. Some airway anomalies are readily observable, such as micrognathia or craniofacial anomalies such as Crouzon syndrome. Previous trauma to the upper airway will predispose patient to airway obstruction. These include injury to the nasopharynx, presence of foreign body, burn, fracture, granuloma or stenosis that result from prolonged intubation, and some congenital skin and mucosal diseases. Inflammatory condition of the airway usually involves infection by different organisms, causing swelling and obstruction at the level of the pharynx, larynx, tonsils, and trachea. Neoplastic condition may involve teratoma, cystic hygroma, or tumor that cause obstruction at the level of nasopharynx, tongue, mandible, larynx, and mediastinum next to the trachea. The American Society of Anesthesiologists classification should then be used to determine the physical status. Class 1 and 2 are considered low risk, while Class 3 and beyond are considered increased or high risk for sedation. Apart from ASA classification, high-risk populations also include history of airway obstruction or difficult airway, neuromuscular diseases affecting respiratory and brainstem function, poorly controlled seizure or asthma, full stomach or acute abdomen, and preterm infants below 60 weeks post-conceptional age. Doctors doing the assessment should be familiar with calculation of post-conceptual age, which is gestational age plus actual age. Other high-risk populations include compromised respiratory or hemodynamic status, obesity, uncontrolled gastroesophageal reflux, severe developmental delay, history of airway collapse during GA or sedation, history of failed sedation, over-sedation or paradoxical reaction to sedation. Now, regarding the procedure factors during pre-sedation assessment, we should take note of the duration of sedative used, any need for analgesic for painful procedure, position of the neck that may compromise the airway, distressful procedure that may cause patient anxiety, and availability of rescue resources. Next, we will talk about preparation for sedation. First and foremost, we should be aware of the risk of aspiration in patients with inadequate fasting, which occur in around 2 per 10,000 procedures. On the other hand, we should also balance the risk and benefit of urgent procedural sedation, even if patient is having inadequate fasting. In fact, long fasting may cause feeling of hunger and stress in infants and children, increasing the risk of failed sedation. In view of that, there is a recent modification of fasting guideline from the previous 2-4-6-8 rule to the new 1-4-6-8 rule. Clear fluid, not more than 3 ml per kilo, is now allowed up to 1 hour before procedural sedation. If chlorohydrate is used as the sole agent, milk feeding is allowed up to 2 hours before sedation. However, the above rule should be modified in patients with delayed gastric emptying, such as gastroesophageal reflux disease, renal failure, cerebral palsy, and various GI conditions. We should balance the risk and benefit of the urgent procedure, use of oral contrast, pre-medication with H2 blockers or proton pump inhibitors may be considered in case of GER. Next, we will look at the personnel involved in sedation used in non-painful, non-invasive procedures such as echocardiography, electrodiagnostic, and neuroimaging. These relatively low-risk procedures can be monitored by trained healthcare personnel, such as patient care assistants, after assessment by doctor in charge. PCA should have ready access to communication tools such as DAC phone, intercom, or call bell in case of emergency. Patients at increased risk of sedation should be monitored by doctors or nurses instead, regardless of the drug used. For procedure under IV or moderate sedation, doctors or nurses should be present to escort and monitor. Doctors are responsible for administration and monitoring throughout the procedure. It is a good practice to have another nurse or doctor to assist and monitor IV sedation. In case the doctor administering the sedation is also the one performing the procedure, then a second medical staff should be present and be dedicated to provide continuous monitoring. Deep sedation should be given and monitored by a dedicated doctor or anesthesiologist throughout the procedure. A second experienced nurse or doctor who is not engaged in the procedure should be present to assist the sedation and monitoring. Doctors and nurses responsible for procedural sedation should gain good understanding of the basic physiology related to pediatric sedation. They should familiarize themselves with sedation drug dosage and be able to recognize and manage adverse drug reaction or overdose. They should also maintain proficiency in airway management and skills in CPR. At least one of them should have attended relevant training course in pediatric sedation and life support. They should also be updated on the latest sedation guidelines. Informed consent and patient education are two important aspects in pediatric sedation. Healthcare professionals should clearly explain the sedation plan, risks and potential adverse events to parents and patients. Fasting practice should be emphasized. Use of current medication should be reviewed with parents. Parental presence during sedation and pre-sedation sleep deprivation are options that can be considered. Patient care after discharge should be thoroughly explained. Regarding the procedure-specific requirement for sedation, we need to know that the radiologic examination is done for diagnostic or therapeutic reasons. Level of sedation required actually varies among different patients and different procedures. The venue for radiological investigation should be adequately equipped and staffed. Protection against radiation should be done via the use of lead apron. CCTV is useful for remote monitoring. Although modern CT scan is a brief procedure, presence of parents or the use of distraction tools is conducive to the procedure. X-ray contrast is frequently used during procedure. Doctors should be able to recognize emergence of adverse reaction and allergic reaction to contrast. Doctors should also know the potential hazards of MRI in patients with certain implanted objects, like pacemaker or cochlear implant. Besides, use of gadolinium contrast is associated with systemic and skin fibrosis in patients with renal failure. Patient equipment are classified as MR safe, conditional, or unsafe. Equipment brought to the MRI venue should be MRI compatible to avoid burn injury to patients. In case of the need to resuscitate, patient should be quickly moved out of the MRI scan room. There are non-painful and non-invasive procedures that need only light to moderate sedation. Examples include echocardiogram or electrodiagnostic procedures. For these procedures, oral sedation is usually adequate. Patient can be monitored and escorted by trained healthcare personnel mentioned before. For short and painful procedures like biopsy, bone marrow aspiration, or LP, etc., midazolam, local anesthetics, or fentanyl can be considered. Failure to sedate is a reason for postponement or referral to an anesthesiologist. On the other hand, painful and invasive procedures like bronchoscopy and GI endoscopy require IV drugs to attain deep sedation. A dedicated, experienced medical staff should be present to provide sedation, airway support, and monitoring. If possible, anesthesiologist is recommended for the above purposes. The aim is to allow the endoscopist to focus on the procedure. Lastly, capnography may be considered for GI endoscopy, although evidence for its use is not robust. In summary, all children must be assessed prior to procedural sedation. Appropriate preparation is able to decrease the risk of sedation. Specific requirements for different procedures must be met to provide a safe and efficient sedation process. That's the end of this talk.